Or is it Amelia? Fab. Thank you, everybody, for joining us this morning. Our speakers will be imminently, but we've got a few minutes just to welcome everybody in, and I'm going to just explain a little bit about the Child Health and Wellbeing Network. So if you're not familiar with us, it's just a bit of an overview of who we are, what we do, and thank you for joining us in our huddle this morning. So I'm Jenny Hicken. I'm one of the network delivery managers in the team. Sorry, just make sure people are muted when they come on. Brilliant, thank you. Yeah, a couple of bits of housekeeping. Do make sure that you're muted if you're not talking, and also do feel free to use the chat function throughout this morning, because we'll use that to collate comments and questions for the discussion section in the second half of the session this morning. So please feel free to raise any questions or any comments as the speakers are talking through this morning. So if we just move through these initial slides. So we are the Child Health and Wellbeing Network. We cover the North East and North Cumbria footprint of the North East and North Cumbria Integrated Care Board. So we're all the way from the top of Northumberland down to North Yorkshire and then over to West Cumbria. Well-known and well-documented challenges for our cohort of children and young people in this region. Lots of issues around child poverty, as we know, and I'm sure you're all aware of, and some key health challenges as well. So these are what we are trying to address, and we work very collaboratively across the system with lots of system partners and stakeholders who are all doing great work, and we try and coordinate some of that. Next slide, please. Thank you. This is just to show a bit of our journey from when we started in 2018 with a bunch of very enthusiastic professionals, some great engagement work that we did from some initial engagement events that led to where we are today, sitting within the ICB via NHS England. So we are very much sort of formally part of the system now, which is great. And we've really been on a journey with some great people that we've worked with along the way and continue to work with now. Thank you. Next slide. So this is just to show our vision. This is what I was talking about, collaborative work, and we believe that all children will be best served by us all working together as organisations and individuals. And what we're doing today is some of this sharing good practice, driving work forward and connecting people together. So that's a big function of these Huddle events that we run, is just bringing people in the system together. And that's our priorities wheel that you can just see there, children, young people and families in the centre, and some of those key issues around the outside, all of which sort of interlink, and then we underpin them with some enablers and some cross-cutting themes as well. And that's just some of those sort of key headline challenges that we face in our region that you can see there as well. Population-wise, when we talk about young people up to the age of 17, it's about 20% of the population in the region. If we take that up to 25, as we do when we're talking about young people with additional needs, that takes it up to about 30% of the population. So it's a not unsubstantial number of people that we talk about when we're talking about children and young people. And it's a very important cohort to focus on when we're talking about all age approaches as well. Make sure that they're not forgotten about. This is a resource that we have on our website, on the ICB website, which will be updated soon, hopefully, because they've just got a new website there, so we're going to get some new content on there as well. But this is a resource that we've had available for quite a while now, but it still stands. It's facts of life, created from public health data that was available in 2021. And if anything, I imagine a lot of the indicators are probably there or thereabouts, if not worse in some cases, thanks to the impact of COVID as well. But it's a great data resource for you to use if you're interested in looking at some of the key issues in your locality and around some key issues as well. Our network reach, we have over 2,000 members now. We need to update our slide, I think. But we do have a great membership across the system, really broad reach. And we have a fantastic reach into youth voice networks, other professional networks as well. And then we do have our own email bulletin and comms that we put out through our social media as well. So if you do want to be a member, if you aren't already, there's a QR code there, and I'm sure one of my colleagues will pop in the chat the link for you to join the network. So If you weren't familiar with us before today and you just come across the Huddle, do please join, and then it'll make sure that you receive any further communications from us and any other opportunities to get involved in future. Thank you. I did just touch on the youth voice networks that we link into. We have our own dedicated group of young people called the Know Our Impact Group, who we work with directly, and they act as our youth board to go with our adult professional board. And they have created this amazing manifesto around how they want as young people to engage with adult professionals. And there's a video on YouTube there as well that you can link to, where they explain all the work that they've done and that artwork that they've created there that you can see at the top. Really worth 5 minutes of your time to look at that. And then just finally, we always end on this quote from Sir Al Ainsley Green, who was really heavily involved in these initial engagement events that we had at the inception of the network. And he was the first Children's Commissioner for England. And this is just really highlights the importance of us advocating for children who otherwise aren't listened to and have very little voice within the system. So that's a big part of our role, and a big part of the people that we work with is just speak up for these issues that need addressing, one of which being oral health is very pertinent to us, which is why we're all here today. So having said that, I'm going to hand over to Heather Corlett, who is our programme lead in the Child Health and Wellbeing Network, and is going to expertly chair the session for us today and lead us through the presentations and the discussion. Thank you, Heather.
Fabulous. Thank you ever so much, Jen. And I'll be keen to know when Ollie and Greg are on the session as well. I haven't spotted them join us yet. But I'm delighted to be here today to chair this huddle. And as you know, we're going to be focusing on what can we do to work together to improve children's oral health. Well, Jen's already mentioned that it's one of the key purposes of the network. Is that remit of sharing good practice. And for those of you on the session today, I really want to ask you to both take something away from the session, but also please do share, use the chat function. It's a two-way street. It's about sharing what we know and that Ollie and Greg and their experiences, but also it's gaining from the rich tapestry of all the people that I've seen in the chat. We're delighted to have you. So oral health is something that I don't think I need to say to all you attending, both in person now and watching the recording afterwards, how important it is. You know it's important, and that's why you've joined us today. But I think what we're starting to notice is its increasing importance in the system. So I was just going to say a quick word on that. So nationally, I think the interest has been evidenced in both the governance and NHS England's programmes, such as the elective recovery programme and the weights for teeth extraction for young people, and the health action plan that the government has announced, and the recent supervised toothbrushing to prevent decay, as well as the consultation that was particularly relevant for us in the North East and North Cumbria on water fluoridation and the increase that we're going to have into new areas within our region. But also a bit more closer to home, it's really important for the ICB, and they have their giving our children the best start in life priority. And what that is to do is to enable them to thrive, to have great futures and improve lives for generations to come. Well, what better way than through a focus with oral health? And they also have their ICB's Children and Young Persons Clinical Plan, and oral health is explicitly mentioned in there. And indeed, both Ollie and Greg have helped us in the preparation for that within the ICB. So it's of great importance to many people right now, and it's critical that we all hear about the work and share thoughts and our experiences today to start building that future for oral health. So I'm hoping I can now pass to today's speakers. Oh, I can see Ollie says we're here. Fabulous. So I'm delighted to introduce Oliver Sumner, who is a consultant in paediatric dentistry at Newcastle Dental Hospital and also the Teesside Community Dental Service. Ollie's the co-chair of the North East and North Cumbria Paediatric Dentistry Clinical Network, which aims to ensure all children in the region can access high quality dental care. And Greg Taylor, who is from NIHR's he's a clinical lecturer in paediatric dentistry, and he's a practicing paediatric dentist. And I'm really pleased that his research is focusing on trying to address the gap of evidence for children and young persons' pathways for oral health. But my favourite bit of particular note for the network, and Jen shared with you our commitment to youth voice, was his focus on the importance of child voice in his recent DECIDE study. So Ollie and Greg, over to you. Thanks ever so much. And don't forget to use the chat function, please, everyone. Thank you.
Thanks, Heather. And can you hear us? I'm just going to double check.
Yes, we can.
Yeah.
Yes. Great. Yeah, so good morning, and thanks everyone for joining us. We're going to spend the next little while doing a bit of teamwork talking about oral health and its importance. If we move slides. So yeah, we're going to talk a lot about oral health, why it matters, why it's really important, some of the challenges both on a national level, but also giving it a bit of a regional focus. That is slightly doom and gloomy. So then hopefully we're going to move on to some of the opportunities that are coming our way in terms of toothbrushing, water fluoridation, and other sort of innovative opportunities that are presenting themselves to improve children's oral health in the region at the moment. Next slide. So dental caries presents in a really wide range of kind of presentations, but it is essentially holes in teeth that look anything like this. It will look like a bit of tooth is missing. They can look like the bottom left picture there, sort of stumps of teeth left that are generally quite dark coloured, black, brown. And on the top right hand side there, they can then present with these infections. So a little abscess, people will often call them a little gum boil. And it's something that sadly is incredibly common, particularly in our area, and in young children and young people, can have a huge impact on them. Next slide. It can lead to pain. Anyone that has had toothache themselves or has children that have had toothache will know that toothache's a particularly horrible feeling. It's quite severe pain. It keeps people up at night. It wakes them up at night. It can affect your ability to eat. It can have a massive impact on your quality of life. But more than that, for children, it can mean time off school, either because they've been sent home from school in pain, or they can't manage to go to school. They aren't sleeping at night, so they're sleeping during the daytime. But they also then need to take time off school, and parents need to take time off work to get dental treatment. That can have wider implications on a whole family. But for the young person missing perhaps multiple days off school, it will start to really impact on their educational outcomes. And actually, if this is continues over a long period of time, can start to have a really significant effect on their education and their overall development and reduce school performance. Next slide. So this is a slightly old slide now, but some research that was done in the Northwest found that a quarter of children had missed days off school because of toothache, and on average they were missing 3 days. It also, like I said, has a larger impact on a family, for parents having to take time off work to either be with their child when they're not at school and to then seek treatment. And that all starts to then have a cost and an impact on a wider society level. So dental decay and dental caries is a massive problem. It affects, these were figures from last year, it affects about maybe 25 to 30% of 5-year-old children have some obvious decay. So the graph on the left is a big epidemiological study. And this is dentists that go into schools and do a brief screen. So this is obvious decay. This isn't sitting in a dental chair having x-rays taken. This is looking in a mouth and being able to see a pretty obvious hole. And for a fairly developed, meant to be well-off country, the fact that 30% of our 5-year-olds are walking around with decay in their teeth, which is essentially a preventable condition, should really shock and upset most people. For us in the northeast, we sit slightly higher than the average. We're not the worst in the country, but we are definitely higher than average. And again, that's sort of demonstrated in that slide on the right-hand side. Both the northeast and North Cumbria have slightly worse or higher rates of dental decay than elsewhere. Next slide. And this also, we know that dental caries has a massive inequality. We know that children from the more deprived areas have more or higher rates of dental caries. And that graph on the right demonstrates a trend over time. So the green sort of turquoise line at the top is the most deprived, purple line at the bottom, least deprived, and the orange is the average. And over time, there has been a decrease in the rate of decay in children. However, there has always and still exists a massive inequality, and that hasn't really changed. It fluctuates a little bit, but that overall trend hasn't massively changed. Next slide. This just demonstrates the number of children that have been seen by an NHS dentist. So these are kind of pulled out of NHS Business Service Authority figures, so it doesn't cover any private dentistry. And you can see there that in our region, we're doing slightly better than elsewhere. However, we're still only having 58% of children that have been seen by a dentist within the last year. Generally, for a child, that's the minimum length of time that you'd want them to go before seeing a dentist. And most people would really be, or should be really seen every 6 months or even every 3 months. So we're missing out on 42% of our children there. But again, faring slightly better than the rest of England. Next slide. And we do have slightly more dentists per 100,000 population than the rest of the country. However, if you move on to the next slides, the graph there on the left indicates dental activity, and we'll talk a little bit about this and how it's not a great measure or how it's a bit difficult to measure, but our dentists that are here aren't delivering as much NHS activity as they are commissioned or kind of planned to deliver. There's a number of reasons for that. And earlier I was saying that toothache can often lead to significant pain and infection. And we know that a lot of these children, particularly if they can't access a dentist in a relevant or a timely manner, will present at A&E. And in the northeast and Yorkshire, again, we sit roughly in the middle of A&E visits due to dental problems. Next slide, please. So at this point, I think I'm going to hand over to Greg for a while.
Yeah, so thanks, Ollie, for that. So as you can see with the sort of prevalence and epidemiological data that we've had, that dental decay from a numbers point of view in the raw data is a significant problem. But actually, more recently, I'm sure most of you will see the kind of impact that it has at a national level in terms of the press and the public's opinions and what's kind of almost going on with the real dental issues that we have in the country. And these are a wide range of newspaper hits within the last sort of year or two, looking from, again, a wide variety of newspapers here. So kind of apolitical in terms of their stance, that generally there is a sense across the UK that this is a significant problem. As you can see here, that 1 in 6 kids are having rotten teeth and the number of hospital needs for extractions are rising. This is all really significant, particularly as Ollie's mentioned, that we're in a developed country. And this is something that we should be really quite ashamed of as a country. Next slide. So in terms of that, we've also looked at the prevalence and the impact, but there's also a financial impact as well. And today, the number of children who have to go to hospital for extractions, it still is the kind of most common reason for a child in the UK to have an elective general anaesthetic is for dental extractions. And as you can see in the year of 23-24, there's most recent published data about a couple of weeks ago. Actually, this is almost pushing on 50,000 children have had extractions done in this age range within the UK, and about two-thirds of them are down due to dental decay. But what the most staggering thing is the actual cost that this is costing our society, our NHS, and again for a wholly preventable condition. We're talking about almost £46 million for decay-related tooth extractions alone in that 1 year. Just think what we could do if we even had half of that money to be redistributed to prevention, for example, or other opportunities. So it is a significant problem. Next slide. So actually what you can see here is the trend of the tooth decay rates over. And again, the dark blue is the number of tooth extractions due to decay. The light green is due to extractions due to other conditions. And as you can definitely see, there was a trend of things going down before we hit the pandemic. And I think we're still really seeing this lag in terms of the number of extractions that are there. And I do suspect this trend's only going to go up and up with the current access issues that we're going to come on to talk about. Certainly, there might be also suggestions that the number of decayed extractions might be less because we get better at coding in terms of identifying what teeth are for. But I think as the overall number of extractions do surpass that initial 62,000 in 2013, we're going to see the increase of well above that 41,000, which is the kind of highest of record in the last 10 years. So although this picture maybe presents a slightly rosier idea, I do think it's going to be more detrimental in the years coming through. Next, please. And that's also just to think about this last thinking about costs, is that these particular costs are only for extractions that are done whilst under general anaesthetic. There are lots of other things to consider about prevention in dental decay, about the cost of treating it by other non-extraction methods or treatment done in the primary care setting, or thinking about actually how much lost productivity is done because parents are not being able to take their kids are having to take time off work, and the sort of impact that has on the gross, the GDP of the country. So there are other things to consider than just purely the cost of extraction. So it's probably a much higher figure than that 46 million would relate to. Next slide. So this is where really helpfully actually it obviously became quite a high priority for the NHS. And this Core 20 plus 5 innovation and targeted approach really started to kind of key home the issue here that actually the number of teeth having to be taken under general anaesthetic is astronomical in this country. And oral health was one of the 5 priority key areas which were identified. In addition to that, also we know, and we've explained already this morning, that it is a disease of inequality. So therefore it really starts to unpick this and to sort of understand how do we improve this. And it's great that there was a national focus as a result of this, and I think the opportunities that are now arising as a result of it with government investment, etc., are only really as a kind of result of this real push from a national front. Next slide, please. But what's also considered as well is we've talked about the impact in terms of cost, we've talked about the impact in quality of life, but actually there was quite a number of children have real impacts on their own self-awareness and their quality of life. We were looking at here potentially sort of a third of children are really embarrassed to smile or laugh because of their teeth. And yeah, there might be other reasons because of that than decay, but there'll be a high proportion of children that will have decay that will be contributing to this. And even more than that, 1 in 5 children have difficulty eating because of result. This is really detrimental that 1 in 5 children walking around in the UK and young population with 12 to 15-year-olds here are unable to eat properly due to the difficulties they're having with their teeth. This is again a statistic that's we shouldn't be proud of. Next slide, please. So just as a bit of a reminder then, as we've mentioned again several times, that dental caries is a preventable condition. And it's kind of the most prevalent condition globally, as well as the number of extractions when you look at the sort of wider epidemiological data. But ultimately, it's actually a relatively simple thing to stop. Next slide, please. Because prevention is definitely better than cure. This is a disease profile that's caused by bacteria, which actually is absorbed by the sugars we eat in our diet that produce acids, cause holes in teeth. And if we can reduce the sugar intake that we have, and we also make sure we disrupt the biofilm or disrupt that plaque with toothbrushing and apply fluoride in the toothpaste to kind of help remineralize what's gone there, these are really simple messages that should be able to be obtained. Now, we know there's a significant cost of living crisis, and with that, a kind of oral health hygiene poverty that's linking into this. So it's not just as simple as we should be brushing better. We've got to really work with people who have inequalities and who are in those most deprived areas to make sure that they can afford to do this. But as I said, as a method, it's a relatively straightforward method to prevent this preventable condition. Next slide, please. Next slide. Yeah, so as you can see here, actually, if we just stop the sugars, as we can see from this cross here, that in effect will therefore mean the bacteria can't produce any acid. So often our kind of key messages are about, yes, reducing the quantity of sugary hits and sugary intakes, but it's also the frequency that's the important. It's making sure that these children are not constantly having sugar bathed over their teeth, which is causing this demineralization, this acid production process on a regular basis. And actually, that means that reducing intermittent snacking. So if they're in schools, for example, trying to make sure that any snacks are maintained to meal times or kind of lunch times are kept as treats. And then likewise with brushing this in terms of either supervised toothbrushing programs or having brushing done in the home and supporting that, that again disrupts that bacteria. So therefore the sugars that we do have are less likely to then be acid producing and causing diet. So again, it's a very simple process. If you remove the sugar, you don't have holes. If you make sure the bacteria is disrupted, you're less likely to have holes. Next slide, please. And this is the sort of key things that we've talked about there, that prevention really is key, making sure that's a really focused, dentally healthy diet. And certainly children who are accessing food through food, for example, that might be particularly challenging, and there's obviously struggles that these families face. And there's work that we're certainly doing in the Northeast here with myself and Dr. Wakeling, who knows on the call, and others within the university who are looking to sort of almost say, how do we address that these patients who are struggling have a dentally healthy diet. There's also some advocacy and lobbying. We'll come on to talk about that later. But thorough dental hygiene, fluoride products, and these regular checks all combine together to be essential prevention for these children. Next slide, please. And we also think about as well about where can different impact preventive measures happen. And we can think about prevention in terms of downstream, where it's almost that individual patient impact, that clinical care, that one-on-one sort of and the chair side, these midstream measures where actually the sort of individual gets the social benefit and the social improvement, but it still has that individual impact. Or we have more upstream measures such as community water fluoridation, such supervised toothbrushing program as an example, where actually there's a severe community and population impact. And we can think about prevention at different levels, and it's important that all prevention that we consider, it kind of targets all of these areas rather than just focusing on one to make sure we get as much universal coverage as we can. Next slide.
So I'm going to talk a little bit about access to dentistry, and this is something that most people have probably heard something about because it has been in the news an awful lot in the last few months and the last couple of years. And anyone that perhaps is slightly older than me will perhaps remember the early to mid noughties, which was the last time that dental access really became a massive problem that triggered a huge change in the NHS dental contract. But we're starting to kind of come back to this, and the things that really strike me are this picture down there in the middle of new NHS dental practices opening and having queues of people just wanting to register as patients with them. Next slide. So it's a really complicated picture because if you look at the number of registrants on the General Dental Council list, so this is dentists and dental care professionals, so it will include dental nurses, but also hygienists and therapists who will do some simple, straightforward dental treatment. The number of registrants, so the number of dentists, is actually increasing. It was up 2.5% this year compared to last year, and dental care professionals up nearly 5%. Yet people are really struggling to see a dentist. So how is this? It's not a dental workforce crisis as such. I think this is more of an NHS dental workforce crisis. So dentists are starting to choose more between NHS or private. And for a number of years, there has been a very blended model where most dentists, certainly in the high street kind of primary care dental practices, did bits of both. So they probably do 2/3 NHS and a bit of private work. And they're now dropping their NHS contracts, they're giving them back, they're leaving that, and they're moving wholly private. And I'd imagine quite a lot of people have had some experience of this, with perhaps having letters or contacts from your dental practice saying, we're no longer going to see any NHS patients, you can pay them, go privately, but we're stopping our NHS work. And again, the reasons for that are huge and probably multifactorial, but one of the main drivers, as well as sort of wanting to do the best care for patients and being able to spend more time and money providing that care, is that actually most dental practices operate as small businesses, and the funding that comes, like everything, funding that comes from government for this has been massively tightened over the last 5 to 10 years, to the point where these businesses actually aren't making any money, or they're only existing because of the income that they generate on a private basis. And I've just put there these band 1, 2, 3 courses of treatment. If you've been to a dentist recently, you probably had, again, some experience of this. But it's just worth pointing out that the dental practice doesn't get this money. They collect your fees on behalf of the NHS. They're paid via a very different mechanism. They're paid by activity, so units of dental activity, which fit into these courses. But let's say you need a filling, you're in a band 2, you will pay for a certain amount of treatment, whether that's a few fillings or quite a lot of fillings. But I just, wanted to make the point that the dental practice doesn't get this money, because otherwise you'd think, well, I've been paying and every year my fees go up. It's not quite the case. It's a lot more complicated than that. Next slide. The other thing that is important to try and get across in a again, fairly complicated thing to try and make sound simple, is that registration doesn't actually exist. So we ask patients, are they registered with a dentist? You probably will feel that you might be registered with a dentist. That actually doesn't exist. So in 2006, there was a huge contract change. And prior to that, there had been some element of capitation or registration, a bit like you're registered with a general medical practice. That now doesn't exist, but a lot of people, dentists, practices, patients still use the term, which is confusing. So every practice does have a patient book, a kind of a list of patients that they see regularly, and that will go up and down depending on their capacity. And every now and again, they might open that book and take on new patients. But they're not under any particular obligation to see a patient, because that registration, that kind of care doesn't exist. And lots of patients can be quite unreliable. A practice is perfectly entitled to stop seeing a patient, particularly if they don't come to a number of appointments. Next slide. So moving on to then more sort of specialist care, so secondary, tertiary care within paediatric dentistry in the Northeast is focused primarily on Newcastle. So the dental hospital, which is at the back of the RVI in Newcastle, provides the bulk of kind of specialist care, but then there is an increasing amount of care now being provided within community services. So there are specialists and consultants that are based within Teesside, County Durham, Darlington and Northumbria. And there is a move to try and push more of this into the community, where it's better for patients. We're quite a large geographical area. There is no good reason why someone should have to drive from the other side of Cumbria to come to Newcastle to have some dental care, or to drive from Berwick or Redcar to come to Newcastle. It should be being done closer to them. Next slide. We're quite a small workforce that cover, like I said, a large geographical area and a large patient area. And the most of what we do as kind of specialist paediatric dentists is a lot of sedation, a lot of general anaesthetic for patients that can't, for whatever reason, manage to have treatment done in the chair. Perhaps it's complicated, or they're very young, or they're very anxious. We work with a number of multidisciplinary teams with children that are medically compromised or medically complex, and other vulnerable groups, children with behavioural challenges, special educational needs, that sort of thing. Next slide. So we said there is a massive access crisis within primary care, and that is having a knock-on impact upon our secondary care services, and that's one of the reasons why waiting lists pretty much across the region are going up. So some of this relates from COVID as well, when dental care and dental provision kind of really shut down essentially for a couple of months and had a lot of complications restarting. So I think we're seeing children presenting or having an increased burden of disease, perhaps because they're not going to see the dentist every 6 months, they're not having that regular prevention, and they're not having problems identified at an early stage where it might be slightly easier to manage. So they're coming a lot later on. They're coming once they've had pain and infection. They might have had that for quite a long time. They might have had repeated courses of antibiotics or repeated need for analgesics. I think we're also seeing children that are generally more anxious, and therefore their treatment needs are slightly more complicated. And again, some of that perhaps is because they're not going to see the dentist regularly. They're going infrequently when they're in pain, when their dentist is perhaps feeling pressured into trying to do some treatment, some emergency treatment in someone that's in pain, hasn't been sleeping, and that hasn't gone very well, and perhaps that's increasing anxiety. So we're seeing more and more referrals into secondary care settings across the system, and waiting lists going up as a result of that. So it's having a massive knock on both the children, but also our services. Next slide. So I think that was a lot of doom and gloom and kind of scene setting on where we are. We're going to try and be slightly more optimistic and talk about how we might improve things for people.
So next slide, please. Yeah, so we're going to talk a little bit now about some new initiatives. So they're not new initiatives, but initiatives that have gained some recent traction, both on a national level and also locally. And most of you who keep a keen interest on kind of government press releases and within health will have noticed that the government released the funding for up to 600,000 children for supervised toothbrushing programs as a widespread universal coverage. In just a couple of 2 weeks ago, this was announced. Next slide, please. So this is an investment of just £11 million from the government, which is going to be rolled out for early years education, some 3 to 5 year olds in a national sense across England. And the whole aim is that we're aiming to target these supervised toothbrushing programs to those who are the most deprived. So again, really focusing on that area of inequality in different parts of England. Although there's not huge amounts of details yet about how the money is going to be allocated to different regions, and then how the most deprived areas within these regions are then going to be allocated. So there's still some working out to do with that, but it definitely is a step in the right direction that prevention at a national that sort of mid to upstream level is approached. And also this has also been really helpful that sort of the likes of Colgate have been the main contributors and are donating quite a large number of toothbrushes and toothpastes, and have committed to do so over the next 5 years. But there is a little bit of skepticism from my kind of thinking, my own opinion, is that, well, that's all and well good for the 5 years, but where do we go thereafter? And I'm hoping that this is going to be a kind of routine investment from the government, that it's not just going to be a sort of 5 year. Probably want to see this being rolled out kind of almost universally on a year by year basis. Next slide, please. So you can see here there's some two infographics of the England itself. And if we look on the left-hand side, first of all, of the screen, this is the kind of status of where supervised toothbrushing programs are currently being offered within the sort of different commissioning boards. And as you can see there, the kind of dark black colours are areas or local authorities that have already got supervised toothbrushing programs in place, whereas the bright yellow are where there is no provision of that. And the colours in between are kind of almost a sense where people are planning to start or might have already started but stopped and would be thinking about doing it in the future. Whereas actually that looks all well and good that you see, well, there's a huge areas already covered. But actually, when you look at the right graph here, actually it shows a slightly stark different picture, that only in some areas are there actually a large volume of children who are actually registered to have those toothbrushing programs or who are identified, with most of the areas in that sort of yellow colour only really covering between 1 and 2,500 children. So actually, although it seems to be quite prevalent, which is fantastic and great, the actual numbers of children receiving this are still quite limited in certain areas. And particularly if we focus in the northeast here, we can see that there's some coverage areas where there's no programs at all, and actually there's a really limited number of children who are having that. It's still fantastic that it's going on, and it's better than having nothing, but this hopeful investment will significantly improve that. Next slide, please. And why is supervised toothbrushing program really helpful? Well, in terms of return on investment, it provides a good return on investment that for every £1 you spend, you see £3 returned after 5 years to the health service, which is fantastic. And in most schemes, particularly this Child Smile evaluation, so Child Smile is really the envy of most dental countries, is a national prevention programme which is run through Scotland and has been doing so for well over sort of almost coming up for 15 years now. I was fortunate that I remember being taught it as an undergraduate at Glasgow when it was just initially being rolled out after its feasibility phase. And they have toothbrushing programs in every primary school across the sort of majority of Scotland, and this is government funded year on year. And the government have bought into this idea that it saves money, that actually it costs not a huge amount per annum, but it really makes a big difference in terms of return on investment. And actually, from the Child Smile evaluation work that they've done, they've seen that the coverage is fantastic, that actually almost 94% of these children in the highest deprived area have got access to this toothbrushing program, which is absolutely fantastic to see. And hopefully this is something that in England we can replicate in due course. Next slide, please. In terms of supporting, if there are people in the call who are from an educational background and who are maybe looking at starting to set up their own programs, or who are one of these sort of fortunate local authorities that are giving some funding, and there's a really fantastic resource which has been rolled out through the University of Leeds and Sheffield by colleagues in paediatric dentistry who've developed these brush optimizing programs, and there's some really fantastic resources on there for educators, for providers, for commissioners, for also the professionals as well. So I'd highly recommend that you can go and have a look at that thereafter. Next slide, please. Next slide. What's also been really helpful as well is actually the recent announcement of the expansion of the water fluoridation that's happening in the northeast. And again, in terms of return on investment for actually making money back for the NHS in terms of its benefit, this is the best fit mechanism for that. But also it's got real wide universal coverage. Next slide, please. So there's a lot of concerns, though, about community water fluoridation. Yes, in terms of it's a universal coverage. It certainly has the impact that it has in terms of reduction in dental decay. But there's still some people have some concerns about it and thinking, well, does it actually work and is it effective? And actually, when you look at the majority of the kind of evidence reviews, they do conclude that it's effective for both children and adult. And that's looking at when you look at pool data, or if you look at individual studies in the UK, such as the Lotus study or the Catfish study that's been done recently, have suggested this. And even if you look at the health monitoring studies across different schemes that are already existing in the UK over the past 4 years, there seems to be that there is this evidence of decreasing decay rates being much lower of children who are having severe caries in community water fluoride schemes, that actually the hospital extraction rates are lower as well. So there is a suggestion that it is effective. Next slide, please. They also think about what's said universal coverage, and I've said the expansion of the community water fluoridation is great, but does it actually help reduce oral health inequalities? Well, in theory, it should do, because CWF as an approach doesn't rely on individual behaviour change that we talked about with toothbrushing, for example. This is something that just children can get from having the tap, for example. You don't have to attend a dental clinic, you don't have to attend a screening for this, so it should, in theory, have a reduction and kind of be equivalent for all children in the region. And likewise to that, it has a minimal cost to the consumer at the point of it receiving that. Yes, there'll be water charges, and yes, that they'll indirectly pay this through their taxation. But in terms of the cost out of pocket to that consumer, it's pretty minimal. Next slide, please. And likewise, the analysis and the evidence that's looked up this has actually suggested that there is greater benefits for these deprived communities. And when you look at the evidence about deprivation, you can actually see that where areas have had water exposure, that there's no evidence in certain studies like this. The catfish that Michaela Goodwin did in Cumbria actually would identify that deprivation itself influences that between the exposure of water being drunk and the presence of decay. So it all again suggesting good, promising aspects. Next slide, please. Is it good value for money? And often when we think about preventing and interventions, that is really the most important thing for certain stakeholders. And generally, the operating costs are pretty minimal in terms of about 50 pence per year per person. And that would fall on the local authorities. And as I mentioned already, it's got the kind of greatest return on investment in terms of the kind of prevention strategies that we have, with the York Consortium and sort of 10 years ago almost suggesting it'd be £22 return for every pound spent after the 10 years. So yes, it might be quite expensive to put in initially, but the benefits would start to be seen in a financial sense over the longer term. Next slide, please. There's one of the biggest concerns in oppositions is actually community water fluoridation safe. And if you look at the public consultation that just recently came out with regards to the community water fluoridation expansion, that was some of the biggest concerns that people were discussing. Now, fluoride's naturally present in some drinking water. For example, Hartlepool in the northeast has got natural fluoride in it. And when you look at the World Health Organization standards for community water fluoridation, they allow up to 1.5 milligrams per litre, which is kind of like 1.5 times the target what most people would want. So the kind of optimum you're looking at about is 1 milligram per litre of fluoride. So we're below that standard there. That's kind of where they deem to be sort of safe. But actually, when you think about safety, there's fluoride in many sort of different foods, particularly tea, for example, where actually there's quite a high significant fluoride content. And I remember as well, also as an undergraduate, being taught Newcastle Brown Ale had a high fluoride content, and it would be accepted as an answer in any of our exam papers, again, because it was made from water in the northeast, although I now think it's brewed in Belgium, so maybe that would be an acceptable answer in an exam now. But it definitely in suggesting that it is a safe procedure, a safe intervention. Next slide, please. There are, however, some common adverse effects, and that would make sense with any excessive fluoride consumption. And there's a number of these that you can consider, but the two that's kind of most prominently considered is what we call dental fluorosis, which is a kind of almost white mottling of the teeth from a kind of aesthetic point of view, and cognitive impairment. Next slide, please. But certainly from a point of view of this sort of scientific consensus that it is effective and that it is a safe public health measure. And these adverse events such as cognitive impairment and sort of dental fluorosis, skeletal fluorosis, yes, they can occur, but it's very much a dose response. And we're looking at doses that are significantly well above the recommended dose threshold that we're looking for to be added to the water fluoride content. And again, it is very much suggesting that it is a safe public health measure. Next slide, please. We've also got to think as well about the sustainability, and that's important, particularly in healthcare as we move forward. And from a point of view of providing general anaesthetics and providing sedation and treatment for these dental caries, actually a lot of the greenhouse gases that are produced have quite a high carbon footprint and are not often sustainable. In terms of the community water fluoridation, there's not a huge amount of convincing evidence yet, but certainly from some of the early work that's been done by some colleagues in this sort of field, we suggest that it does have the lowest environmental impact in terms of all fluoride preventive delivery methods. And actually, in general, as we mentioned, reducing disease is a big priority because it reduces the impact burden of care. Next slide, please. Next slide. So just kind of thinking of almost coming to the end of the presentation here of the next sort of 5-6 minutes. Actually, we know that the current access issues have real problems, and optimising prevention is really important, but it can have detrimental effects if children can't get access to the dentist. And certainly the recovery plan looking at reorientation of services, whilst its value in prevention, I think still needs to remunerate both equitably and fairly for dentists. Next slide, please. And again, that's my opinion. in the Northeast, we were really fortunate here to be part of the sort of N8 research group, which looked at these sort of wider public health strategies. And one of the kind of key components was how oral health and improving that can be worked through with education settings. And this was a really lovely document that was produced that certainly myself and colleagues in the university were privy and part of this. Next slide, please. There's also innovative methods, and you might have seen as well that we were very fortunate to bring the DentAid charity bus up to the Northeast and provide dental care for 5 days, working with food banks at Byker and Benwell. And certainly the appointments were made by the food bank, and there was some walk-in. There was an element of triage as well. And you can see this sort of just some of the pictures here of the staff who were providing the care, but also the undergraduate dental students here who were supporting the prevention aspect of that. Next slide, please. Over the course of that week, we saw 64 patients, the majority of whom were adults who stayed on the bus, but got a wide range of treatments. But in addition to that, we actually screened 141 children and provided them with a prevention as well as fluoride varnish and coatings. And I think one of the biggest lessons we learned there was actually that it was a much wider societal problem than just not being able to access the dentist. We looked after children. I remember Louisa, a colleague, was looking after a dog and holding a young children. We were taking people from in cars from the rain because it was pounding with rain. So there's a real sense as well that there was a need for this particular care. There's some research that's come out of this, which we'll present or discuss at another day, but it just almost looked at the barriers of these children and adults accessing care and how community partnerships can really bring forth maybe a way to kind of overcome this. Next slide, please. So as I mentioned, this screening here, this is a kind of one of the what we offered in addition to the mobile dental bus coming. And you can see the sort of team of people who are providing this. Next slide, please. And again, as I've mentioned prior to this, over the 5 days, we saw 141 children who were majority quite young children, early to young children. And the good thing, actually, is that there was quite a lot of them were in relatively good oral health, and again, at a very obvious decay level. So they didn't have a thorough examination, x-rays, for example, but there's kind of not necessarily those big holes that you would see. But the sort of rates that we were seeing in terms of the patients who were in pain and how much impact in their life and the decay rates we saw were very much in keeping with the national average, if not slightly worse. So it was good in a reassurance way, but it still fits in with what we're seeing nationally. Next slide, please. Of these 141 children, they all got a prevention hit, so optimizing that every contact counts. They all had fluoride, 125 of them had fluoride varnish, and another had 15 had a different type of approach. One of the big things of this is that the prevention was given with the undergraduates from the university, and toothbrush and toothpaste packs were disseminated. And those children who really needed treatment were directed to our student clinic for treatment to have done. And of the 48 that were directed, 37 have attended. So again, really demonstrating that these children who needed it most have been picked up. And as Ollie said, if we can get things earlier, we hopefully can get to that point and deal with their issues sooner rather than making it all just about extracting when things are too late. Next slide, please. And we're also very fortunate that we got a bit of both local and national coverage from the BBC, being on BBC Breakfast. And this is a picture on the left of my sister who was having her breakfast at, we'll go about 8:30 in the morning, and she saw My Ugly Muck came up on the BBC Breakfast, which she was particularly dumbstruck by. But it got a lot of traction here, which was fantastic, and again, really helped support that. Next slide, please. There hopefully are plans to consider doing this again, and certainly we're looking to repeat this potentially in places like the Granger Market and others about how we're working with voluntary sectors. Next slide. We've got to think about, though, is this scalable to other areas in the Northeast? And this is certainly an opportunity that we have. We don't always just want to refer patients to the dental hospital because of the geographical disparities that Ollie's mentioned and the cost of impact that it might have on the patient. They may be looking at sort of having child-friendly practices across the Northeast and providing upskilling dentists and incentivizing them properly to be able to take these children. So there definitely is a mechanism that this could be a really good way to kind of cover this access and this chaotic lifestyle of children. But there's got to be considerable investment from the budget holders to ensure this is scalable. Next slide, please. I'm going to hand back to Ollie.
Next slide. So we are nearly at the end. I suppose the title is How Can We All Work Together? We wanted to try and bring some ideas and really a kind of plea for help. So there was this document, evidence-based plan that was meant to work through education settings, and its main kind of findings, some of that is very national kind of big picture stuff. So reducing sugar consumption. So the soft drinks sugar tax levy really has started to kick in, and is there's a lot of evidence to suggest that dental decay rates are decreasing because of this. And trying to think about other kind of big national pictures that will impact. But some of this is much more local, some of it's closer to home in our nurseries and our schools, regional programs like water fluoridation and supervised toothbrushing. And even if it is building better oral health kind of education and awareness into national and local curricula, and kind of focusing on this at a much earlier stage, it is far too late. By the time a child reaches either Greg or I, they've got decay in numerous teeth. It is far too late for us to sit there saying, oh, well, you need to brush your teeth and stop eating less sugar. This needs to happen at a much earlier stage, and it needs to be kind of just more established and built into people's lives, really. Next slide. There is certainly some advantage to targeting more vulnerable groups, and things like sort of labeling on sugars. A lot of it, like I said, is education and awareness. There's a lot of hidden sugars. There's a lot of foods that people consume believing they're quite healthy. So they'll often come and say, oh, we have a lot of fruit juice or fruit shoots or things like that. Sauces, a lot of packaged foods, they are full of sugars that people don't actually really fully realize are. So if we had better awareness of this and better labeling, perhaps that will start to make some impact as well. Next slide. And then there are some really kind of innovative, exciting things going on. So the picture on the left, there's a town, I think it's Swindon, are using dental nurses to go into schools to provide oral health education, and a range of kind of different things to just make talking about toothbrushing and teeth more fun. And I've got no idea about the one on the right. It's something in Devon or Cornwall involving Professor Green. But it's a really innovative, whatever it is, innovative, exciting, different way of getting people to engage with oral health messages. Next slide. So to summarize, hopefully we've kind of made you feel like oral health matters. We've presented some of the challenges that providing oral health and improving oral health in the North East and North Cumbria has. We talked a bit about sort of national initiatives, supervised toothbrushing, community water fluoridation schemes, and hopefully these will have a real impact. It's really positive to see oral health being taken more seriously, is in the news and being addressed. And as Greg's talked about, some innovative approaches on a much more local, regional basis about screening children for oral health problems and just advocating for them to try and get this preventative message across, so that people don't have to come and have lots of teeth taken out, and they don't have pain, and they're not missing time off school for something that can and should be prevented. There are some really good resources. So the British Society of Paediatric Dentistry has a lot of resources, and this supervised toothbrushing whole website, if you are at all interested or involved in setting up supervised toothbrushing schemes, there's loads of stuff on there to look at. And I think that's it. Thank you.
Wow, thank you so much. That was fabulous. I feel like I've had a full education about the sort of the causes, the challenges and the opportunities that we've got in oral health. I'm really excited. And the chat box has been quiet because I think everyone's been so engrossed in what you've been sharing. And we've got the fabulous panel that I'll introduce after the break with Chris, Louisa and Jill. But before we break, I just wanted to say, that data was fabulous, and thank you that draw, because I hadn't highlighted at the beginning the importance of poverty within all this. And of course, we've got national and regional strategies around that. But I know for this, and you picked it up at the end again, Ollie, it's about working together. So what's that collective action? What can we do together to progress some of this, to really emphasise and take forward some of the initiatives. So whilst we're all on a 5-minute break, I'm hoping people will let that kind of cogitate through a bit, and we will have some questions. I know we've got some shared ready for the panel that they're going to focus on as well. But it'd be great if we had some tangible things about progressing the supervised toothbrushing within schools, and how we might do that together. So thank you very much, and if we can take a short break. You are absolutely dead on time, so well done to not only present that well but to time. Isn't easy, so thank you for that. We will see you back in 5 minutes. Oh, we're 5 minutes over. I won't take it back though, it's still fabulous. We will see you at 11:05. Thank you. Don't forget to pop things in the chat. So I think we're at 11:05. And thank you to those of you who have popped some questions in the chat. And I'd just like to welcome, as people are popping their cameras back on and joining us for this second part of the Huddle, which is the opportunity for questions and answers session, both with Ollie and Greg, but also with our panel members. And it just helps us to bring some of the discussion alive, especially when some people are either watching the recording back are a bit shy on the chat. We have people active and ready within the room. So our panel members, I'm delighted to introduce Chris, Louisa and Jill. Professor Chris Veneza, who is the head of the School of Dental Sciences and Professor of Oral Health Services and an honorary consultant in paediatric dentistry. So welcome, Chris. I can't see your
Thank you. Yes.
camera on yet. Oh, you are here. Welcome.
Yeah.
Thank
Great
you.
to be here. And just to say, I'm really sorry I couldn't make the first hour, so apologies if anything I say in the discussion repeats what's already been said or doesn't quite follow, but yeah, I'll see what I can do.
I'm sure it won't, but you missed a fantastic scene setting, very comprehensive. So that's great. So welcome, and colleagues can see a more detailed biography of members at the bottom of the agenda. I also welcome Dr. Louisa Wakeling, and I can see Louisa there. That's fabulous. You're a senior lecturer at the School of Dental Sciences and Director of Engagement and Place at the Faculty of Medical Sciences. So welcome to you. And finally, over to Jill Gray. And Jill, I haven't seen Jill yet, but she is, I'll
yes,
let you
I'm
come
here.
off mute. Oh, hi, welcome, Jill. You're a Senior Partnership and Innovation Officer at Wallsend Children's Community. So it's fabulous to have you and your 40 years experience with us today. Before we go, I thought we'd start with the questions that are in the chat, but also whilst people are listening, just to highlight some of the questions that we thought as panel members you might like to bring in and draw out. And it's around what can we do for children with the decay, some of the barriers, referencing your experiences and that families face when accessing care, and how can community hubs and organisations be important in supporting child oral health. And we saw some examples of that with the bus going to the food banks, and I know we've got neighbourhood MDTs very much on the agenda in NHS. Queries around why dentists are moving away from the NHS, and then finally around that important role for teachers and educators in terms of oral health improvement. So if that percolates in, and can we go to the questions? So I know Rihanna couldn't join us, but there is a comment in a chat and a document that she's been trying to share, but that if it's not already been added into the chat, we can share that with the resources that come out at the end. So hopefully that will be fabulously helpful. So the next comment was around Greta, Professor Greta de Fater, and some of the work that you're involved in. Greta, would you like to come off mute and share a bit of that? Not at this moment. Okie doke. So in that case, it's over to Jen. And I know there's been some resources put in the chat, but do you want to just share your question?
I think Greta's saying she can't unmute.
Oh, can't she?
I was going to see if I could unmute for her, but it seems not. Anyway, yeah, no, mine was quite a specific question, I guess. But it's one that's quite wide ranging an issue, I believe. So I know you touched on it previously when you were talking around the difficulties for children with additional needs in tolerating toothbrushing, and sort of getting them into the routine of doing it, but also the sort of actually practically brushing their teeth sufficiently and that sort of thing. If there's any advice around that. I know Penny's just shared some great resources in the chat, that are on the Northumbria Trust website, which are great. But just anything from your professional perspective around support for that group of young people, and also around encouraging them to visit the dentist as well.
Fabulous, thanks, Jen. So over to Ollie and Greg, you've got your hands up.
Yeah, shall I take that? I suppose there isn't an easy answer. I'd love to sit here and say, try this and it will change everything. But trial and error and persistence. So some children, particularly very sensory, kind of oral sensory and oral aversion, really dislike anything going in the mouth, including a toothbrush. You can get lots of different toothpastes, which are non-flavored and non-foaming, which to your eye taste and feel horrible because it doesn't taste like a toothpaste. It doesn't feel like the minty clean kind of feeling that you want your teeth to have. But that's exactly the point. So some of them are like Oranus, OHP. If you Google kind of non-flavored, non-foaming toothpaste, there are a load of different brands. Just make sure that they have some fluoride in them. They should, for a children's toothpaste, certainly an older child should have 1,450 parts per million fluoride in them, which most will, unless it specifically says it's fluoride free. So different toothpastes, and then a bit of trial and error with brushing as well. So sometimes an electric toothbrush is really good. It's a bit of a novelty, and some people really like that vibration. They find it a lot easier. You can just move it around from tooth to tooth. On the flip side, some people absolutely hate the vibration and would just like a normal, perhaps quite a small and quite a soft regular toothbrush. There's nothing wrong with that if you're using it in a proper way. And then if you're really struggling, you can get multi-headed toothbrushes that look like a normal toothbrush with sides on them, and they're really good because as a parent you feel like you are getting more brushing done in the very limited window that you might be able to get a brush in there and actually kind of be able to do any kind of toothbrushing. But I'd normally say to people, even if children are kind of picking up a toothbrush, looking at it, kind of playing with it and then putting it in their mouths, that's a really positive step. And biting on it and chewing on it is certainly going to be disrupting all the bits of food and bacteria that sit on teeth, is better than nothing. And then just trying to build that into a bit of a routine. There are lots of apps that kind of help with times, or even just putting a video. So we're currently in my house, we're big fans of Hey Dougie toothbrushing. So something like that, a YouTube video, just to kind of give a bit of distraction. But really it is trial and error, I'm afraid.
I think just to add to that, if supervised toothbrushing programs were going to be introduced in schools where special education needs children are, it might be better that because of that routine that they're used to, and if they're doing things at home that aren't the convention, suddenly disrupting their oral health regimes by doing it in school with something different, a different toothbrush or a different brand, really could be detrimental. So I think in these circumstances, it's really having good communication with the parents and making sure that whatever has been done in school is then being what's been replicated at home, which is really important for these children with neurodisabilities, neurodiversity, to make sure that they're compliant.
Super, thank you. Lots of helpful guidance there. And then Jill's got a hand up, and then Chris, I think they want to follow up, and Greta's given us thumbs up.
Just 2 points from me, really. We work with a group of community champions across the Wallsend area. So I asked them for their stories before I came on today, and SEND children came up quite a lot. So it's not so much the toothbrushing at home. They had some really good tips for each other, such as a lot of them do toothbrushing in the bath because 1, the child can't run away, and 2, they can make a bit of a game. Just the other point was that a lot of the neurodiverse children are in mainstream school. I think within a special school, you probably already have it as part of your routine of your care for the child anyway. They often do the oral health in schools. If it's going to be new to a mainstream school, this could create a lot of problems. But parents have very mixed views on that, on whether they feel it should be done at school or not. But one of the issues they do have is getting a dentist that will give them a long enough appointment for their child to be used to being in the room, being in the chair. We've had mixed reviews, some saying absolutely brilliant, I get a double appointment every time because they know my child struggles, from other people saying they've taken me off their list because they can't cope with my child.
Very difficult to hear that. Thank you, Jill. 2 really helpful points. Chris?
That follows on really nicely from Jill's comment, actually. I was going to speak about the kind of dental services side of things. And I think, I mean, there are lots of good pockets of really excellent practice nationally and in the region. But we're not very good at sharing that within our dental networks. And also, I think there are lots of places where we could do a lot better. And certainly the dental hospital where I work, I don't think we do as well as we could do. So I think there's a lot of learning for us, and actually the network and what the people on the call today, the people in the wider network, I think actually we as dentists could learn a lot from the expertise in the network. So just picking up on that earlier theme of, you know, working together and us learning from those that are really expert in this area.
Fabulous, thank you ever so much. And I'm going to write a list of actions, because this is about working together. And I think this is the first action is following this question, that we will gather together both the resources that have been shared to cascade out to everyone that's on the huddle today, but also with that commitment for that onward cascade, and any best practice and bits that Chris, yourself, or other colleagues on the call can share, then we will cascade those in perhaps a separate specific comms relating to this. We have also got the action around Brianna's information, and also Greta's, because it's unfortunately Greta can't get off mute to share it, but Greta, we'd love to hear more about your number 10 initiative that you could share with us as well. So Ollie and Greg.
Yeah, I'd just like to pick up, I was reading the comments there of the chat and what Rhiannon had mentioned, which is the ICB of the practices, I think. So there's commissioned dental practices across the region have been commissioned for additional services with urgent and high needs. And I think this is great in many ways, that there's sort of commissioning of these services to try and deal with the access issues. But certainly I think there needs to be advocacy and lobbying for child oral health, that it's not just for getting the tooth out, that child out of pain with that sort of single tooth. There are long courses of treatment here. And certainly utilising some innovative, flexible commissioning approaches, and really kind of pushing the commissioners to say, well, how are we going to get around this access problem? Because it's brilliant having preventive strategies that are going to resolve it's not going to be the panacea of everything. They're still going to have children who need dental care who are not accessing it currently. So as much as that's fantastic, I think there still needs to be some advocating and lobbying, and certainly people in this call are the sort of the champions of that to really promote that and can help us in doing so.
Absolutely, and I think that's a really important point, and I think the panel members might need to come in on that also, the importance of flexible commissioning and different approaches, acknowledging that, you know, the resource from Rhiannon is really helpful, but it's the firefighting, isn't it? But at least it's giving those families access when the need is greatest, if you like. But Louisa, I don't want to put you on the spot, but if you'd like to come in on that point, or if not, Jill or Chris.
I think, you know, sort of using an example of a mother who we spoke to, who attended the food bank with her child, who was living with a neurodivergence. It is that flexibility in access. You know, she told us about that child having a good day when they were quite happy to visit the dentist. You know, this child was in pain. They've actually entered secondary school and they still have baby teeth, and it's causing them a lot of problems. And that child wanted that sorted out, but, you know, on a bad day they didn't really want to visit the dentist, but on a good day they would. That mother had real difficulty getting an appointment, so she doesn't have the luxury of choice. And you know, she's been removed from the books because she's had to cancel before, you know, and it's that kind of flexibility in the provision that we just don't have, you know, let alone any provision really when people can't get appointments. So yeah, I just wanted to share that story.
Super. Do you think that and other stories might be useful for us to share with colleagues and it may be that colleagues are fully aware of these examples, but there's nothing like a real life example to bring to life some of those challenges. So if people felt that was useful and they had some they could share, we could definitely collate those and pass them on to colleagues if that's helpful. So Chris.
Yeah, I mean, maybe we can develop the discussion a bit more about why the NHS dental system's in such a crisis, and that does make doing anything here really difficult, actually. But there are examples in other regions where they've invested or developed this idea of child-friendly dental practices. Some places have kind of shied away from that name because all dental practices should be child-friendly, but maybe they're not. So child-focused dental practices is another way that some regions have developed that. We've not developed that in our own region, but it does, it's not specifically for SEND children, obviously, but it does give you some confidence that the dental team there will be willing to make adaptations, better at dealing with these sorts of things. And I guess, again, thinking about working together, that might be one thing that this network, the Child Health and Wellbeing Network, could take forward and advocate for in a different bit of the ICB and try and put a bit of pressure on the dental commissioners. We as dentists can make these recommendations, but often, you know, we're one of many voices speaking to the dental commissioners. If it's coming from people outside of dentistry, it's always that much more powerful.
Fabulous. So it's the sharing of that example to gain some traction, isn't it? And alongside that, I think Greta's added in the chat. I know Amelia's going to help me with the chat, trying to keep up with it. But Greta's popped in there a kind of strategic approach to developing a regional co-designed blueprint across services informed by research and practice to give us something to use for lobbying. And I'm sure that there is some work underway to start that. But please do give your support as an approach, because again we can say that during this session there was a lot of support for that approach, and we can be that united voice if you like. Lovely. So Amelia, I'm going to come to you in a moment on the chat, but Chris, Jill and Louisa, just thinking back to those questions about what we can do for the children, what are the barriers, how can community hubs and organisations be important? Why do you think the dentists are moving away from the NHS? And that important role of teachers and educators in oral health improvement. Who would like to go first to give some comments on any of those elements?
I will, Heather. So
Thank you.
I think for me, obviously, I'm not a dentist, but just observing people and engaging with people, you know, I think as a group, we've really learned a lot from actually being in the community setting, and I think we don't quite realise the complexity of the barriers until you actually start, you know, embedding yourself into a community hub and understanding, you know, people's stories. And I think, you know, we kind of anticipated costs and transport would be issues, but actually the complex needs of those families really came to light. And what actually struck me most about working in the food bank, but also other community hubs as well, is the knowledge that and experience that the community leaders have in really understanding their populations and what they need, what they want, but also how we can actually help them. How can we, you know, help with prevention in terms of oral health in that community? And it's the community leaders that really understand what works. And you know, they were the ones that were saying, right, it's raining, I will have to go and get these people in my car, otherwise they will not come, you know, to this intervention. And it was things like that. And as Greg mentioned before in the slides, you know, people arriving with multiple children. We were looking after, you know, several children at any one time and trying to support families so that they could actually access the care that they needed. They, you know, the mother could spend time with one child in that dental chair, allowing them to be screened, allowing the fluoride varnish to be applied, and we were looking after the other children and looking after dogs and helping people fill in forms where, you know, English wasn't their first language, where, you know, they actually didn't have much literacy, people couldn't read and write, and that all in that community setting was feasible. We could do it there, and I think there's something to be explored there, you know, more about how actually we can get care to people, and you know, as Greg said, we then were able to signpost to the hospital, and I think that's another major sort of way we can help. It's those tools for signposting, allowing those community leaders to know where, you know, to send people when they're coming in to use facilities. And actually, you know, we had a lot of information on people arriving at the community hub with dental problems. You know, that the classic is ringing 111, but as we know, not everybody can qualify for that. They can't get an appointment at the local practice. Where do they go, and what do they do? So I think equipping community leaders more so with signposting would be a really helpful initiative as well.
Fabulous. That's really helpful to hear, and it aligns with our Healthier Together approach, and they have which is our website and app for children, young people and families. And there's a community, a champions approach, where it's those trusted peers in the communities that are working with the specific needs of those communities that are best placed to advise and influence and share information. So we can definitely share resources on how that approach has been taken by our colleague Laura in our Healthier Together programme. So we need an approach that's community specific. It has clear signposting and includes those important community leaders. Penny, do you want to come off mute and just, I can see you put a question in the chat there regarding academy trusts. Oh, sorry, Jill, do you want to come back on that point before I go to Penny?
Yes, thanks. It was just to follow on what Louisa said about the community. And a lot of the community champions have mentioned when they were younger, a dentist used to come into school and check your teeth. But I have also spoken to GPs who said that they're getting more and more people turning up at their practice with oral health problems, which they can't help them with. So they just have to refer on, which they do. But one of the factors that's been mentioned a couple of times is if the parents aren't able to get a dentist, there's no role model for the children, and that is a big issue, that the parents are saying if they can get the children seen, they'll do that first before themselves. But actually maybe we need a bit more education out there about how being a good role model. I don't know about anybody else on the call. I go to the dentist because my parents went to the dentist. My children and grandchildren
norm,
go.
isn't it?
It's just what we do in our family, and I think we're missing that a little bit. So I think definitely
Ollie or Greg might want to come in on that as well. Jill,
yeah,
sorry, didn't mean to.
That's fine. Definitely some education to the parents.
Important point.
Totally agree with you there, Jill. And I think education, behaviour change, role modelling is hugely important. And there will be a majority of the population, or a proportion of the population, who just don't value oral health, and that we can never change people's values and their opinions in that. And that will then naturally stem on to their children, which is unfortunate. But there are a population who probably want to value their oral health, but just don't have that access, as you say. So it is limiting. I think the one thing I was just looking is that I think we do have a real opportunity here of working well with schools and education sectors, and probably coming on to Penny's point about the academy trusts here, because actually the majority of children access school on a regular basis, and it's a kind of an easy audience to capture. And it's almost whether these scalable sort of screenings that we've been doing with community partnerships and organisation could be something that's led with the ICB in terms of commissioning these services to have almost screening done in education settings, but almost then directing into those child-focused practices that Professor Bernat's has talked about there. So it just needs a bit more logistical thinking. And I mean, there are ways that can get around that. And yes, there needs investment. And yes, is it truly feasible and scalable? But if we've got a population to check, schools definitely are the sort of way they're having to, target just community sort of organisations. They're fantastic for those who've got chaotic lifestyles. which we know so don't always necessarily access school, and they've got these trusted champions. But we've got to work both organisations, and I think education and community organisations are definitely combined the way forward, working together.
Fabulous. And I think on our to-do list, our action list, that sort of general comms around the importance of oral health, and then the targeted towards schools and parents in schools. Pamela, is it specifically this item you want to come back on?
Yeah, sort of, and it's maybe more of a comment rather than a question or a but from a health visitor point of view, I think you've made some good points about this generation of people or this that we've seemed to have that don't value or don't seem to recognise good oral health when we're talking to younger parents, perhaps even parents in their 20s, and asking about, do you see a dentist? Talking to them, even when their babies are like 6-7 weeks old, about the importance of brushing when their teeth emerge. These messages seem to get lost. And then you'll see them at 1 and they've got a mouthful of teeth. Have you started brushing? Oh, I didn't know we had to. And then you'll see them again at 2. Oh, well, we try and do it every day, but not always. There just doesn't seem to be in a lot of the families that we see an importance for oral health. And I don't know, as our health visitors, what other resources that we can use to change that, because I guess wait until they get to school, even at 3 and 4, could be too late for a lot of these kids.
Yeah, that communication and message is so important, because you want these families and young people to appreciate the importance to it, and not appreciate it when it's after the effect. So a really key point, getting in there with maternity as well. So this communication seems to be key. Ollie and Greg?
Just to comment on Pamela, with regards to health visitor, again, there's a really good resource called Habit, which is a website which has been designed through the University of Leeds about supporting health visitors in providing early child oral health education. I'm sure it's Habit it's called. I'll try and find it, put it on the chat here. But there's lots of good resources there that are available to support health visitors in providing oral health education. And if it's not on the website, I'll find where it is and send it to Jennifer and the team to send on to you, Pamela. But there definitely is some resources out there for that.
Oh, that would be really good. Thank you.
Super, and we'll add that to the bumper edition. Louisa, and just Penny, after Louisa, you come in to articulate your question to us. Louisa, go on.
Yeah, I was just going to mention, I think we have Sean Soulsby on the call from the Children's Foundation, and they've just got some funding to put toothbrushes into baby boxes, and we actually, Greg and I and another member of staff at the dental school have a PhD student who's going to start looking at actually, is that the right time? Is it how are the messages taken up sort of when the child is very small, and obviously we spoke about earlier about introducing this awareness about oral health as early as possible for that family. So we'll obviously keep you updated on that work. But yeah, just to say that we're looking at things there with the baby boxes. So that's a really exciting project.
Yeah, fabulous. It sounds it, and it is a really key time, isn't it, to get in as early as you can. So we look forward to hearing how the results of that come through. So Penny, would you like to share with us your question?
Yes, I'm a community paediatrician, and so I'd just like to echo about the importance of building relationships and getting children as part of their family to go with the family to the dentist, because it may be just getting them through the door. The sights, the sounds, the smells can be quite overwhelming for children with neurodiversity. So again, it's all about that children learn through their eyes. So modeling those habits, particularly for children who have neurodiversity, is absolutely key. And yeah, there's some absolutely fantastic practices, but access to NHS dentistry is a real issue for where I work. But I work across North Tyneside and Northumberland, and I noticed from your map that Northumberland does not have a supervised brushing programme. And obviously there's a lot, the direction of travel is to multi-academy trusts. So I just wondered if there was any research or any models out there to sort of support introducing that to areas where at the minute there isn't a supervised brushing program? There's been loads of resources, and I guess that's a good place to start, but I just wanted to get the expert view.
Fabulous. Well, Chris is your expert, I think.
Well,
Thanks,
I'm not sure
Chris.
about that, but I can certainly
I'm
signpost.
sure you are.
Yes, so a supervised toothbrushing, one of the most effective, as part of a package of other things, but one of the most effective things we can do, actually, and also one of the most cost effective in terms of the return on investment. So the government actually announced last week that there was going to be a big push to really spread the supervised toothbrushing. So I think there's quite a lot of hope on the horizon for this. They're going to put in quite a substantial amount of money. It's a really interesting public-private partnership with Colgate, which has split opinion a bit, but there we are. That's the way the government are pushing forward with it. That will still be targeted. It won't be a universal measure across all schools, so it will be targeted at more deprived schools. So I don't know whether the particular schools you're thinking about would fall into that. I guess we need to wait and see the details. However, in the meantime, there's been some really good work, mainly out of Leeds and Sheffield, looking at supervised toothbrushing, how we should be doing it, what's currently on offer, where it needs to spread to. I'll try and find a few relevant links and put those in the chat as well. But I think there is a lot of hope on the horizon for supervised toothbrushing.
Thank you. I just wanted to say that in Northumberland, it's a very rural area where I live, so what you see is rural poverty is sort of, it's hidden because the area may be affluent, and so in terms of deciles it doesn't score, but actually there are some incredibly deprived families who also then don't have access to transport and hence dental care, and so all of the other factors, but they're relatively hidden and will not necessarily figure in terms of the school catchment as being an area of particular deprivation. So, but thank you, that's great.
Thank you. And I think Jill just wants to follow up as well on that. Oh, Chris,
Yes.
Sorry. Jill, then Chris.
Just to say, one of the things that we're doing in the schools in Wallsend with the student dentists is the brush up program, and that's really successful. So the student dentists come into the schools and they work with reception class, and they do a session on healthy eating and on brushing your teeth, and we've provided them all with a little pack with some toothpaste, toothbrush and a little timer, so they can take that home and they can do that at home. We encourage the schools to bring the parents into that session as well, and that is really successful. Would love to expand that to kind of gradually take that further than reception and move up the school if there was any chance to do that. But it is a good model to have.
Super, thank you. And it's ideal if they're bringing the parents in, and it's a trusted environment for parents to come, isn't it, the school, which is the great thing. Chris, over to you.
Yeah, I was just going to add one little thing that I forgot to the previous comment, which was that the supervised toothbrushing, because it's oral health promotion activity, would be commissioned through the local authorities rather than the ICB. It's a little bit of a quirk. So if you wanted to put pressure on anyone or advocate, it's the local authorities. But it sounds like somebody, I can't remember who in the chat, has said they've got a bit of intelligence that Northumberland are thinking about that. So that's great. And then just to pick up on Jill's point, really pleased you mentioned Brush Up. We're really proud of that work that our students do here at the dental school. At the moment, we have to be quite limited in the geographical area that they can go out to in terms of travel distance. They all live in central Newcastle pretty much. However, we would be willing to think about expanding that. It is a student-led program rather than a kind of staff or dental school-led thing, but certainly I can put people in touch with the right people there and we can explore potential. It would probably require a bit of funding for their travel actually, but yeah, if there's an appetite, we could certainly look at that.
I'm sure often if there's a will, there's a why. So thank you for that offer. And
just if I could quickly come in there as well. Just so the way we've overcome that is we've Wallsend Children's Community put a little bit of funding in as well, and we've just set up with a local taxi firm that they collect the students and take them back, so there's no outlay for the student, and it's also kind of boosting the economy of Wallsend because these are local drivers who spend their money in Wallsend, so it's win-win really. But if schools are about to get a little bit of funding to have the supervised toothbrushing, then maybe that's something that we can look at doing a pilot across Wallsend of, could they spend a little bit of their funding on supporting a programme like Brush Up, possibly into foundation dentists or something, so there's more capacity within the dental team.
Fabulous idea, and I think we're working together.
Yeah.
We're doing what it says on the tin, so that's fabulous. Can you follow that up out with here? That'd be great. Ollie and Greg?
Yeah, it was just kind of picking up on the point that Penny made about the kind of rural communities. As part of the kind of dental recovery plan, that there was a commission for doing sort of rural bus, sort of for providing care for rural communities and coastal communities. And they were very specific as to which ICBs could actually apply for that. And unfortunately, the North East North Cumbria ICB were not eligible to actually apply for that, so we're almost excluded from that funding from a national NHS, which is a real shame, because as Penny said, we've got quite a large rural and coastal community in this part of the world. So certainly, yeah, that there are other means there, but this is a game where kind of lobbying and advocating at the local ICB level really needs to kind of push that if we've not got that centralised funding available to us, what can we do locally for these rural communities and these coastal communities that we know have got lots of deprivation, lots of social issues, but the geographic disparities that we find as well.
Thank you for that. So I don't think there's any hands up at the moment. Can I just go to Amelia to check if there's anything I need to mop up from the chat? I can see Greta's comment about that's relevant for the Northumberland discussion about when she was trying to get the survey disseminated, but that hasn't happened as yet.
Yeah, sure.
Anything I've missed? Thank you.
Yeah. So Adele has shared that they've trialed some with some SEND schools, and it's had the opposite effect and helped with home brushing. So that's the supervised brushing. So I don't know if Adele would like to add any.
Adele's our system leader for education.
Yeah.
Or is it a different Adele?
I think I'm a different Adele.
Oh, okay.
You can promote me if you wish.
Well, I'm sure we'd love to promote you.
So we're based in Cumbria, and we've had some commissioning from yourselves in the Northeast, specifically for some special education schools. And in 2 of them, it's been particularly successful, to the point where we've also got the sixth form students brushing as well. And the amount of work that's been done with that school has just kind of escalated in a really positive way. And the team member who's really promoted that as the lead, she's kind of become a bit of the family in that special school. So that's been a really positive thing. We have found with one of our other schools, which is logistically not as close to us, where we've not had as frequent visits and things, we have found that's been a little bit of a barrier. And we have found that particular school where you were saying there was some different children who maybe needed that structure and things were a little bit overwhelming. We did kind of reflect on a few different practices with that particular school. But again, I think it's very much dependent on the individual pupils, what's kind of going on in the home environment, and lots of other factors that kind of figure into that. But on the whole, it's been a really positive approach. The children and the schools have welcomed it. And of course, they've been able to have the funding. So they've got the toothbrush and the toothpastes. Those who need the 360 brush or the Dr. Barman's have had those provided. Those who need the non-foaming toothpaste, they've had that. So I think a really big part of it is actually the resources that we can provide when we do these sessions makes a big difference as well. But yeah, that's just a bit on our experience with it. But overall, it's been really positive, and we're really proud of what we've achieved.
Lovely. And any learning that you think or anything you've developed, please do pop in the chat or send later, because you've been through that. Or if people want to share their contacts for another school, if they were about to adopt a similar approach, it's about that learning network and trying to promote this together. So it would be great if that was possible. Adele.
Yeah, absolutely. I'll pop my email address on the chat, and then if someone's got a project coming up, we can obviously just give you some information on what's worked well for us and things like that. Absolutely. Thank you.
Thanks, Adele. Amelia, anything else I've missed? We're coming towards our last 6 minutes of discussion.
Yeah, so Amanda said that she works in a SEND school with children who have complex needs, including autism, and many really suffer and struggle with dental pain. Do you have any recommendations or for help and pathways? So I don't know, Amanda, if you want to expand on that.
Any suggestions in relation to the
I think
responses
Ollie may have
to
answered
it?
that in the
Thanks.
chat, Heather.
Yeah, so Ollie's put a nice comment about really
Lovely.
111 is probably the initial place to go in terms of the pathways, and he's put some analgesic advice as well. I put a sort of more broad comment about I chaired a group that looked at a clinical standard for NHS England nationally for oral healthcare provision in special educational settings, and that clinical standard's out there. The ICB in theory should be commissioning to that standard. I don't think they are universally in our region, so that's something, again, we could put a bit of pressure on. However, there's a whole list of resources on that page that are really useful for people, even if we haven't got that fully commissioned pathway in place. So there's all sorts of templates, guides as to how people can express their pain using visual means, etc. So have a look at that, and there's some really good resources that were developed nationally by the Mini Mouthcare Matters team.
Fabulous. Thank you. So many resources, but if we can just even bring them all together, and we have our lovely Healthier Together platform. So I think one of our actions as a team is to see if there's any way we can help facilitate the sharing of this through that as well. But thank you for that, Chris. So I don't know, could we have closing comments? We've got, we're due to close the discussions at 10 to. So Chris, Jill and Louisa, could we have some closing comments or reflections from yourselves? Thank you. Shall I go to Chris first?
Yeah, I mean, again, apologies, I missed the first hour, so I don't really know what was said there, and I'm sure there was lots of really useful stuff. However, the bit that I've seen, there's a lot of interest and passion, which is always really great for me to see as a dentist. I think we do operate sometimes in silos, don't we, across lots of areas of health. And I think there's a lot we can do by learning together. And of course, that's the real benefit of the Child Health and Wellbeing Network. So yeah, let's keep working together. There's so much good stuff going on. It's a case of joining it all up and trying to make sure it's universal rather than pockets where there are individual champions.
Lovely. Thank you, Chris. Jill?
Just to offer any help with this, we've got 17 schools in Wallsend, and if there's anything that anyone wants to test out or any information that you want, I do have access to people in schools. And one thing about data, I did ask in schools, if a child is absent due to a tooth problem, whether it's for an extraction or toothache, it is classed as an authorized absence. So the data isn't actually there because the data is there for unauthorized absences, but it is, parents won't be fined for it because it's authorized. But a couple of schools have said they could do a bit of digging and find some data of how many children are off. If people think that would be useful, I'll see if I can get some schools to get some data for you.
Fabulous. We've got thumbs up from Chris there and from, super. I think that's a resounding yes. And if you're happy to be contacted, I think anyone that's happy to be contacted, if they could share a sort of summary of what you could offer an opinion or a perspective on, and your contact details, and that will help the team as we gather some of our resources together. Lovely. Thank you, Jill. Louisa?
Yeah, just to say thank you so much for organising this today. It's been really useful, and it's fantastic to see all the resources in the chat and all the initiatives that are ongoing. And I think, if we can tie this together and understand the challenges, the facilitators there in this work that needs to be done, that would be really helpful. So knitting this all together would be a great move forward. And if anybody wants to speak to me about community engagement that we've got on and brush up as well, I'm more than happy to help.
Lovely. Thank you ever so much. Over to Ollie and Greg. Reflections from yourselves or final comments?
Well, I think all I can say just before handing back to Ollie for the final kind of comment of the session, that it's been lovely to see so many people here today who are clearly passionate about oral health of the communities that they work with. And I think hopefully we've been able to demonstrate why oral health matters, some of the kind of expansion of current and innovative preventive packages that are already in place, and some of the stuff we've been doing, which again could be scalable up and if investment was there. And I just kind of echo what's been said before, that community engagement, working with each other, not in silos, and really actively lobbying for oral health to be a priority with the ICB. It's exactly what Chris said earlier on. It's great for us saying it as dentists, but if people out with dental fields lobby for oral health and the impact that it has on their groups, that is often a much stronger voice to the commissioner. So certainly please would have to echo that, and I'll pass over to Ellie.
I'm just going to say the same thing. It's been really interesting. I think we just need to kind of continue this momentum. This has been a really useful, enthusiastic, kind of passionate morning. Let's just keep going with this and make some of these things that we've talked about try and happen.
Fabulous, thank you. Well, I think it leaves me to say a huge thank you for our 5 speakers today. It's been amazing. That context at the beginning, Ollie and Greg, was really, really helpful. And then the views so freely shared with by Chris, Jill and Louisa really helps bring some of that to life. But I think you've all already said some of the reflections that I would like to share, and it's about taking this to the next phase. In your talk at the beginning, you mentioned, with the bus data, we could share that in a couple of months. So there's lots that's still bubbling. So let's have another huddle in several months' time, because as you said, we've got the comms to engage, we've got the lobbying to do, we've got the resources to share, but we can start to bring back some of those examples, and as people are tackling some of the challenges, perhaps have some of the sort of real-time Q&As in the specific projects, as well as liaising with our commissioners that I know are looking at the complexities of commissioning within oral health. So I think it would be fabulous to bring all that together. But thank you. Top marks for the best resource sharing huddle, I think. And I can only apologise to the fabulous team, Jen, Carol and Amelia, that have pulled it all together today, because actually for us to make a difference, I think there's a lot of loose ends that we've got to bring together, and we've got to make sure that we share the resources that you've gifted us here. And then it's incumbent on everyone here today and those watching the recording back to actively engage with those resources. What are the schools that we need to connect with? How can we lobby? What are the comms? And we can go back within the ICB and ask for some of those messages to be shared, and I'm sure everyone can within their organisations. So thank you very much for having me today to chair, and I will hand over to Jen, who is just going to do some on the horizon comments. Thank you.
Okay, thank you. So it's Amelia.
Sorry, Amelia.
It's all right. No problem. Yep, so I'm just going to share a bit about what sort of areas of work we've got leading involved, people can get involved with. So we mentioned about Healthier Together. I popped in the chat the link to the website. It's currently under development and we'll be launching the new site soon. But that gives us a perfect opportunity to pull everything together that you've shared and to do something quite exciting with it. So please, any other resources, please do share. But in the meantime, we'd really appreciate you being able to share the app, the website, into the communities that you work on. So when you visit the app and the website, when you visit the website at the top, there's an opportunity to click and you can access these QR codes, or you can use them from the slides that we will share. But if you've got any other areas that you want to pick up on, our colleague Laura leads on that area of work, and you can set up some time with her. So we have our weekly Child Health Tuesday bulletin, which comes out, and our network members receive that. And currently over 2,000 network members, so that covers the North East and North Cumbria. And if you've got resources, if you've got events, please do share with our main inbox, and we can add those in. We have regular newsletters that we share. We also have growing engagement on our LinkedIn account. We've moved away from Twitter. And we also have opportunities for people to share their areas of work in our system engagement group. So this would be a fantastic opportunity for colleagues here to attend that meeting. It's a bi-monthly meeting, and if you contact our main inbox, we can send you the invite for that. And that's an opportunity just to explore issues that are facing communities across the region. Obviously, we're here with our Huddle program. So in the email that you'll receive the recording, you'll receive the resources, the slides, but also there's a little survey, and in there, if you've got suggestions of any future Huddle topics, it could be oral health related or other areas of or other projects or areas of research, we would love to hear from you as well. There's a range of resources, and I know it's been highlighted before, but the Core 20+5 toolkit, there's quite a lot in there, different projects that are happening across the North East and North Cumbria. And again, Healthy Together's also on social media, so it's on Facebook. So next slide, please, Carol. So, yep, so this will be in the slides and there's bits for you to click in. The one thing that's really important that I haven't mentioned is the influence of our engagement with children and young people. So if you work with children and young people and facilitate engagement, participation, and help advocate for their voices, please do connect in with our Youth Voice Network. We would welcome more organisations to join that. We also have a professional network. So if there are any professional networks that you're involved in, please do fill in the form highlighted there. So final bit from us is just to stay in touch. We've got our email address at the bottom, so that's for our main inbox, which is monitored daily. And again, get in touch with us through our website or via LinkedIn. And there's the QR code to join the network to receive Child Health Tuesday. But huge thank you to our speakers, and thank you very much for the team and our chair for pulling it all together. And you're going to get 4 minutes back. So thank you very much.